a little commentary by Nick Jouriles. Nick, that name might be familiar to you. Nick Jouriles was the president of the American College of Emergency Physicians about 10 years ago and did a great job in that role. Every hat he puts on, he does it well. And in case, he's now the president of the Emergency Department Benchmarking Alliance. Over 1,000 EDs share their data and share their stories and share their information with EDBA. So he's going to let us know sort of the state of the organization and launch us on our journey today. Hey, Nick, thanks so much for being part of this whole thing.
Thanks, Shari. On behalf of the ED Benchmarking Alliance, we want to welcome you to the 2020 Innovations course. We've been doing this course for 15 years in conjunction with the Center for Medical Education, and we think this is a very big possibility and a great course for those of you in ED operations. So who is the EDBA? Well, the Benchmarking Alliance started just like many things in emergency medicine. It started with a question. Many years ago, 26 to be exact, Bruce Janiak was approached by his CEO and asked, Bruce, how come it takes you so long to process patients with asthma? And Bruce thought for a minute and asked back, how do you know? CEO left and Bruce never heard from him again, but thought about the idea and realized that he did not know whether he was good, bad, indifferent, fast, slow, had no clue. So he called his friends locally and they got together and started sharing data. And out of that grew the EDBA. It became a multidisciplinary opportunity to study how we provide care in the emergency department. And the mantra has always been, better data means better operations. So now, more than 25 years later, the EDBA collects data, provides the definitions for the data collection, holds great conferences like this, has a very active listserv where members can get real-time information and help from our colleagues, and also conducts research on ED operations. So who is our membership? Our membership comes from all around the country, and we even have some international members. We represent 1,500 hospitals and roughly 25% of all the emergency departments in the country. And collectively, we have 53 million visits, which is about 1/3 of every visit in the United States. Our members send us their data and we compile that into an annual report. The 2019 data report will be coming out within the next month. It's very easy to access the information. It's reported in a very readable form. And our members can also go to our website, and on our website, they can look at the data, play with the data, compare themselves in any way they want to any of the other members. It's all de-identified, so people don't know which hospital is which, but you can compare yourself to other level 1 trauma centers, other people in your state, other people in your region. You can compare that way. And the database is big enough that we have the comparables. We also hold wonderful courses like this one, the Innovations course. We've also held 4 summits where industry leaders have come together and defined some of the terms that we use every day, such as length of stay, boarding time, arrival time. And those have all been peer-reviewed and published in major journals. We also sponsor research and present them at national meetings. Here, we are presenting at the 2019 SAM meeting, a paper that is subsequently published in JSEP Open. And we also work with regulators in industry such as the Joint Commission. Most recently, we're working with the electronic health record vendors to incorporate our definitions into their products so that the data acquisition will be seamless for our members. We serve as a real-time source of information in exchange with our members. We work with other stakeholders to improve emergency care. More importantly, when someone gets on national news and says blah, blah, blah about emergency department operations, we have the data where we can counter that. So we serve as a sounding board and a referee for our members. So on behalf of our members, we want to welcome you to the 2020 Innovations Conference, and we hope that you enjoy this. We also hope that you come back next year for the 2021 conference so that we can all be together and enjoy each other's company and share ideas so that we can improve emergency care in this country. Thank you.
Well, if there is one person in emergency medicine who has been keeping track of where we've been and where we're going, according to the data, it would be Jim Augustine. Jim Augustine, as many of you know, first started the first data set that was the Emergency Department Benchmarking Alliance, and he has lovingly captured and tracked the data for our specialty. The data that's come out since COVID has been pretty interesting, and EDBA has made quite a point of trying to track what it's telling us. What about this pandemic? What is it doing to emergency medicine? How is it changing our practice? So Jim, who is the vice president of the Benchmarking Alliance and the keeper of the numbers, and in my view, a great thought leader in emergency medicine, he's going to share with us in a TED Talk what's been going on. Thanks, Jim, for joining us. We really appreciate all that you do.
Thank you, Shari. I am Jim Augustine. I serve as the Vice President of the Emergency Department Benchmarking Alliance. And since the beginning of the Alliance, I serve as the data geek. And it is my pleasure to help all of us understand the emergency department operations based on the survey data from our Emergency Department Benchmarking Alliance members. What's really critical about what we are discussing today, this is the last year before coronavirus. So it's the last pre-COVID year. This is going to be a significant operational and patient-related landmark time because it is likely that the changes resulting as in the post-COVID era will change the operations and the function of the emergency department forever. So let's go through what we have learned about emergency departments before 2019. In the years that we have been doing this, there is a very continuous increase in emergency department utilization year over year since World War II. It appears that our survey, which in 2019 involved about 1,200 emergency departments that served over 50 million patients, of the 160 million patients or so that we're seeing, it appears that volume in our sites was about stable 2018 to 2019. 2019 showed further signs of acuity increases and a lower mix of pediatric patients. Long-term trends. What is not changing is the flow through the emergency department with a boarding time of still around 120 minutes that has been stable over the last 7 years. Bed utilization is decreasing, as it should. We have relatively more beds available to take care of patients in the most efficient emergency departments. And another trend of note is that more patient transfers are occurring, particularly from smaller volume EDs to higher volume EDs, and across all EDs, from the acute care medical emergency department to the mental health facilities serving the area for the mental health volume and chemical abuse volume patients that are continuing to come to the emergency department. EDs are performing well in the under 40,000 group, and in particular because it appears high acuity populations and EMS are moving around smaller volume emergency departments. It also appears that EDs over 100,000 volume are functioning very well relative to that 300 plus patients a day that they see. Right now, the average emergency department in this country is seeing between 40 and 60,000 volume per year. And the EDs that are 60 to 100,000 appear to be the most difficult emergency departments to try to manage and operate. So we'll break those figures down as we go through the data talk today to make sure that you understand the numbers. All right. This has been our volume trend. It's the continuation of a line that began about World War II. 2 to 2.5% increases in volume. We use the hard data from the CDC, the National Hospital Ambulatory Medical Care Survey, to post these data numbers year over year. The Benchmarking Alliance assists the CDC in analyzing those numbers. For these many years, there has been a 2 to 2.5% increase that abruptly stopped in 2020. And at the next conference, we'll be talking a lot about what happens 2020 into the future. Nonetheless, even if we look at 2020 as a 150 million volume year, it takes us only about another 6.5 years until we see the next billion patients that are going to visit American emergency departments. A billion patients means by 2027, we will have admitted 190 million patients to the hospital through the emergency department. It means there will be 170 million patients who arrive in an ambulance cart to the emergency department. It will mean essentially all major traumas, STEMIs, strokes, ruptured aneurysms, sepsis, and other high acuity presentation patients will have come through the emergency department by that time. There is a continued volume increase, and a billion patients does not take us long in the American health system to cover that volume. All right, what are the key numbers that you need in managing your emergency department? And where does the volume data in 2019 show that they're going? Number one, pediatric patients are disappearing from the community emergency department. So in full service EDs that are not pediatric emergency departments, the percent of patients that are under age 18 has continued to decrease. From the low 20s over the past few years, we now are down to about 15% of the volume in the emergency department is age under 18. I could show you a converse slide, and it's reflected in Medicare data that over 65 patients, age over 65 patients, continue to increase. Transfers. All right, here is where our cohort mix is first presented to you. So our cohorts presented on essentially all our data reports include the following elements. We have EDs under 20,000, 20 to 40, 40 to 60, and so forth, up to the largest group of ED, up to the largest volume EDs, which are the groups seeing over 120,000 patients a year in their emergency department. The largest ED by volume in our survey is Parkland Hospital in Dallas, Texas. We also segregate out for the surveys EDs that see primarily pediatric patients, EDs that see primarily adult patients, and in a clearly different segment are freestanding emergency departments and a small number of EDs that are specialty service only. Those are typically low volume, serving only women, eye patients, mental health patients, etc. That's a completely segregated group and are not included in other data elements. We then incorporate all of those EDs that are full service into the all ED category that on this slide is reflected on the left-hand side. So the first volume cohort report graph I show you is about how many patients, what percentage of ED patients are transferred out of that emergency department to another emergency department. We see that number very high for the under 20,000 volume emergency departments, going down continuously to the over 120,000 visit emergency departments. Still a significant number for pediatric EDs, and the overall percentage of transfers in emergency departments is about 3.1%. That is a higher number than it has been in prior years. The CDC data report says about half of transfers are related to mental health or chemical abuse patients. that are being sent from the ED where they were first seen to another hospital that services that group of patients. So that's a significant number of patients. And if you run the math on 1.5% of the 150 million patients that are seen, that's over 2 million patient transfers for mental health services or chemical abuse service per year in emergency departments to other hospitals. That's a lot of patients, and it's a lot of risk, very honestly. Otherwise, we have our small volume emergency departments who are part of typically low volume hospitals that are not able to provide a full complex layer of service to all patients that are seen. And since I work in some of those, I appreciate our loss of medical staff results in us not keeping patients who are sicker, and they are transferred out to another full service hospital that can accommodate those patients, typically in a nearby urban area. So a significant challenge to emergency department leaders, depending on their type of EDs, is managing transfers, either transfers in or transfers out. Next volume graph to show you is the trended volume on emergency department length of stay for all patients. From this graph, going back to the first years that we did a complex set of data surveys, the year 2004, we have monitored the length of stay for all patients in emergency departments. That length of stay has been relatively stable around 3 hours. And you can see in particular over the last 6 data years, that number is just about rock solid. So it would appear that particularly in EDs that are over 40,000 visits per year, that a predictable length of stay is 180 minutes. And across the universe of EDs that are 40,000 visits plus, it is very rare that we see an ED with a length of stay that is significantly under 180 minutes. In our small volume EDs, and in particular in EDs that see very low volumes and very low acuities, those EDs move patients very, very quickly. And a 100 to 110 minute average length of stay for all patients is very common. Why we present this is in your planning models and in working with designers and bed planners for the over 40,000 visit EDs, it is really not rational to plan for a length of stay for all patients less than 180 minutes. We've watched for many years the statistic on left before treatment complete. So this is the comprehensive statistic that shows all patients who arrived versus all that left at any point before they were supposed to. No cheating, ED leaders, no cheating. So this is the comprehensive figure that includes eloped, AMAs, left before triage, left after triage, left before medical screening exam, left after medical screening exam. Any of those categories, we combine all of the numbers together, and we find that unfortunately that number is creeping back up again. And across all EDs is just a little under 3%. This is a number we need to continually manage to make sure that when people present for service, that we have the staff and the patient care space needed to fulfill that patient's need to come back and be evaluated and receive whatever treatment is needed. Next, very important concept. The front door to the inpatient service units is the emergency departments. That number has increased over the many years I have been involved in emergency medicine and is now stable at about 70% of inpatients. So the emergency department as the financial and operational front door to the hospital is very real. The other front door to hospital inpatient beds is typically the labor and delivery unit. And in most hospitals that have a full service ED and a full service labor and delivery constitutes about 15% of admissions per year, and the ED about 70% of admissions per year. If you don't have a labor and delivery unit, your relative contribution to admissions should be higher. If you're a hospital that serves as a tertiary or quaternary receiving center, you get relatively more transfer ins by way of MICUs and air ambulances, and the ED's contribution is relatively less. If there are clinics that are part of an academic environment, those may result in more direct admissions. And so the ED's contribution is relatively less. But across the universe of emergency departments in this country, about 70% of inpatients have beds that are filled by patients who are processed in through the emergency department. And that's very important that you remember that number and know how it impacts your hospital. All right, our admissions, very important part of what we do for the hospital. And as I showed you, the ED, the front door to the hospital. In particular, in the higher volume EDs and in adult serving emergency departments, a lot of the patients that come into the emergency department are admitted. It is relatively less in pediatric serving EDs and in low volume emergency departments, particularly those under 20,000 visits per year. So the overall emergency department admission for all patients seen in EDBA emergency departments is 21%. That is an all-time new high number. All right, this is the important operational area and what Shari Welch has had us focus on for many years. A key to the overall functioning of the emergency department is how long do admitted patients stay in a bed, occupying that bed and the time of our nurses from the time a decision is made to admit the patient until that patient leaves the emergency department to go to the inpatient unit. That number has been around 120 minutes across all EDs since volumes started to be collected in 2013. That number gets longer in high volume emergency departments. In particular, the jump occurs at around 60,000 visits per year. This graph shows in the red bar at the lower end, the time from arrival until a decision is made to admit the patient. Across all EDs, that number is between 180 minutes and 250 minutes. So arrival to decision, so that's in the control of the emergency physician and a little bit in control by the computers, where we designate that a patient needs to be admitted at a certain time. And then it clicks a box in the system that says any time from now until patient leaves the ED is a boarding time. The boarding time is really an important negotiation element between the emergency department and the floors. The shorter the time, the better the processing of the admitted patient, the better typically the outcome of the patient is. The quicker they can get put into an inpatient pathway, and the quicker they can move towards discharge of the patient. Therefore, a management strategy that includes working with the hospital to reduce the boarding time for admitted patients in the ED is a very important strategy. Right now, about 40% of the time an admitted patient is in the ED is in the boarding arena. All right, we started collecting this data in 2012 for the EDBA, but in 2013 was the first time that the Hospital Compare website from CMS began to report it. You can see from this graph, and it really should have a larger scale, so it shows there really isn't much time difference, but we're stuck at about the 120-minute level for boarding time across all EDs. That is an opportunity cost for us as ED managers to reduce this time to get admitted patients upstairs to prepare that ED bed and that ED nurse and tech for the next patient that needs to come in and use that bed. All right, a couple very important numbers on the procedure side. We have been watching CT procedures per 100 patients for many years. knowing the implications of that, and our strategies to reduce the use of ionizing radiation on patients in the ED. We have seen over the last 2 years a gradual creep of emergency department patient procedures, CT procedures, that are done. That number is now at 23 procedures per 100 patients seen. It is significantly higher in patients who are seen in a level 1 or 2 trauma center versus the non-trauma centers. So within our database, segregating level 1s and 2s versus non-trauma centers, CT utilization is about 31 procedures per 100 patients in the trauma centers versus 22 CT procedures in non-trauma centers. Explanation of that difference is both PN scanning of trauma patients, plus it is likely that trauma centers also serve as stroke centers and other measures of higher acuity patients. And the CT scanner is used relatively more in higher acuity, specialty-oriented emergency departments. Non-trauma centers still use the CT scanner at a relatively high level, 22 procedures per 100 patients seen, to get the diagnostic information needed to make a quality disposition on the patient. All right, payer mix. What is happening pre-COVID, and then what is likely to happen post-COVID? At this point, the largest payer across all visits to emergency departments is Medicaid. It emerged over the last 10 years to now be, in 2017 in the New Hampshire survey, about 40% of patients arriving in the ED are covered by Medicaid, about 31% by commercial insurers, and about 22% by Medicare. The self-pay numbers have been going down year over year in EDs. The workers' comp have about disappeared. And I put one more class of patients on here, which is the nursing home patient, with a very restrictive definition of what a nursing home is. In the second column, the right-hand column here, I put the admission rate for those groups of patients. You see that Medicare patients, although 22% of ED volume, have a much higher percentage rate of admissions. So for the Medicare patients, if you arrive and are a Medicare covered patient, you have about a 24% chance of being admitted, which is a significantly high number compared to Medicaid at 7.1, commercials at about 10%. The highest admission rate is for the nursing home patient. Again, a restrictive definition of what a nursing home is, but about 40% of patients arriving from a nursing home get admitted to the emergency department. What are we expecting post-COVID? We expect that more commercial patients will arrive. We expect that on an ongoing basis, more Medicare patients will arrive. We expect that with the advent of telehealth and telemedicine, our Medicaid population will continue to decrease. Our Medicaid population also reflects youngsters, children, who again have had a decreasing percentage of arrivals in the emergency department. We anticipate that will continue. Self-pay patients continue to have problems finding access to care, and so will continue to arrive in the emergency department. And nursing home patients, it's hard to predict. There are more and more telehealth options available for nursing homes. There are new EMS-driven programs that allow EMS decision makers to serve nursing home patients with a little bit more than just a transfer to the ED. And it is possible that we will see decreasing utilization of the emergency department by nursing home patients into the future. Very important now for this year is that this calendar year has seen dramatic decreases in the number of patients arriving in emergency departments. You all, as members of the EDBA, contributed your data month by month, January, February, and through the first half of the year. In January and February, we saw volume increases in 2020 versus 2019 based on high flu numbers in the early part of this year. So remember, January, February, a lot of flu in the community, a lot more visits to the ED. In March, COVID arrived in the United States, and people began to fear going to the hospital or going anywhere. And so about the second half of March, we saw drops in volumes in most EDs about 50%. For the full month of April, officially the volume drop was 48%. In May, about 42%. In June, about 21%. And it has been about steady from July through September, where we've had about 16% volume drops nationally, comparing 2020 to 2019. Is that our new norm? Well, potentially it is. Potentially affected again by telemedicine, potentially affected again by other programs that allow access to medical care outside of the ED and outside of the hospital. Nonetheless, at the community level, we need to be prepared for lower volumes but higher acuities. So our take-homes, plan for that lower volume, higher acuity. Make decisions locally to increase the availability of services for mental health and chemical abuse patients. Otherwise, it is very likely, and in particular post-COVID, that those patients will arrive and need to be serviced in the ED with fewer outpatient services unless you are involved locally in improving the service package available. There are some metropolitan areas that have developed sobering centers. They have developed the use of retiring hospitals that serve as mental health service centers and other local formulas for finding a better service package for mental health and chemical abuse patients than simply being processed in every ED in the community. Our ongoing challenge is to improve the quality of services and the safety of services provided in the ED. And at some point, and particularly at the end of this election cycle, it is likely we will need transparency in what the charges will be for service in the ED. That may be, again, another discouragement for patients to come to the ED if they see that there's going to be a very high bill with no insurance coverage. So that's surprise insurance coverage that would result in a heavy copay or out-of-pocket cost for the patient. Our opportunity is to continue to build the case for the value and cost effectiveness of the ED and the prevention that we do so well, and that we continue to evolve the services given to patients with emergent and unscheduled acute care needs. That's the end of the data presentation that summarizes the 2019 Emergency Department Benchmarking Alliance data survey and our opportunity to serve into the future. In a virtual way, I am available for questions that are guided through the Innovations Conference website. And I look forward to working with all of you as we figure out the way into the future for emergency services that are so needed in our community and you deliver so well. Thank you for what you do, and thank you in particular for what you have done this year serving this community in, let's use the term, unprecedented, challenging times. Thank you very much.
Well, I have to tell you, one of the smartest nurses and nurse leaders that I know on the planet is Mike Gibbons, and he is also the administrative and executive director of EDBA. And he's a good friend, so full disclosure. But anyway, Mike knows an awful lot about ancillary services and how they impact and affect our practice in emergency medicine. So he is going to talk about lab and imaging turnaround. He's got some great tips and tricks on the subject. He'll share with you what some of the benchmarks are, which you've all been dying to get a hold of. He's going to share some of the benchmarks for the timestamps and time intervals of imaging and lab, which EDBA has just begun tracking. And he'll share that with you and some best practices that he hopes you'll be able to apply. So Mike, thanks so much for giving us all this information and sharing it, and we'll let you take it away.
Thank you, Shari. And I just want to say thank you to everybody for attending today. My name is Mike Gibbons. I'm the Executive Director of the Emergency Department Benchmarking Alliance. And I have been in this role for about the last 4 years, and I'm here to talk to you today about our latest metrics that we collected for the first time in 2019, and that is imaging and lab turnaround time. We are going to go through some of our findings as well as some best practices that we've identified. And with that, we're going to get right to it. So the process to get this data, our members annually submit data on an annual survey that we send out, typically at the beginning of January. There are about 45 questions on that survey. New for 2019, where we added turnaround time for lab and radiology. We limited that survey to some key tests that we felt were considered decision makers, for example, a lactate, a urinalysis, a CBC. And for each of those tests, for both radiology and for lab, the measure was initial order to the first result available to the provider. And for radiology, that could be a preliminary report or the final report, and the way we qualified that was it was whatever your institution allowed you to act on in terms of decision making. Report that earliest time. That data was requested at the beginning of the year, and we are still getting data in as of yesterday. Obviously, COVID kind of distracted everybody from the normal routine, and getting data in overall for the EDBA this year has been a challenge. So for those of you who were able to submit, I just want to thank you for that. So as we move to our next slide, just the responses that we had overall are listed here for you. Full service EDs, which excludes freestanding ERs and specialty EDs. We had 871 individual facilities report data. Adult only EDs were 130. We had only 8 that were ED super centers this year. And you can just take a look at the rest of those numbers going down there. As usual, that 20 to 40,000 volume band emergency center is consistently the largest N in our database, and that continued again for 2019. So the radiology exams, we asked people to report order to first result available for CT, MRI, plain X-ray, all, not just a chest X-ray. It was just a median time for all plain films ordered out of the ED, and ultrasound. And the way we asked you all to identify that patient type was report for all patients with a location as ED in the electronic medical record or in the radiology information system. So those of you familiar with the EHR, there's always a patient location. And if the patient location was ED, sometimes it's inpatient ED, sometimes outpatient ED, but with the patient location ED, that was the inclusion criteria for patients that qualified for these median time reporting. And again, over the 25 years we've been doing time metrics for emergency medicine, it has been determined that the median far better represents the industry-wide data than does the mean or the average. So just know that if you've not been part of the EDBA in the past, that we always use median for time reporting. So let's go ahead and look at our first result. We have ordered a first result available for CT. Across the board is a pretty consistent 90-ish minute average of all of our different cohorts. So I've broken this into the same categories that I showed you earlier in terms of how many were in each N, so I didn't repeat that here. So all EDs, the average of the medians was 84. And then adult was a little slower than pediatric sites. And you can see that like usual, when we're reporting these time metrics, the lower volume EDs are typically better at throughput in terms of ED metrics, and that has carried through along with the CT time as well. So on average, you can look across there and see that we're about 90 minutes, unless you're in one of those super centers. And again, this was a very small N for those sites that were over 120,000, and that's a limitation of this data. So I just want to be clear about that. Excuse me. Moving on to MRI, the MRI results, you know, they're all over the board. I mean, highly variable, no rhyme or reason in terms of who's getting results back. I mean, it would be interesting to break this data down a little further in terms of, you know, who in our data set is a primary stroke center, and is that a result? Is that MRI? We don't ask for volume; we just ask for median time. So that could be a potential. That could be potentially be something that we'd like to do in the future. To report volume with that median time. But for the first time ever, we are looking at these ancillary times, and you can see MRI definitely no rhyme or reason in terms of how rapidly they get done. You know, we're looking at 410 minutes, 414 minutes. What is that? You know, I'm approaching 6 hours, a little over 6 hours. The average is well over 4. So I would definitely hope that we do not continue the trend of increasing MRIs in the ED unless we can get something, a result back in a reasonable amount of time, because I mean, that is adding more than the average length of stay on top of that visit already. So when 180 minutes average length of stay, add 414 to that, and now you're up to 5 something. So definitely want to avoid MRIs if you possibly can. It's just a long process across the board, no matter where you are. Those 60 to 100,000 volume band EDs are certainly getting hurt the worst. There's probably a volume bump in terms of number of scanners available between the 100 and 120 plus sized supercenter ERs. Anyway, something for a little food for thought. Order to first result available for Xray. This was very consistent, surprisingly, across the board. Standard deviation of 25 minutes with that, and with the average of the medians being 74. Very little difference between adult and pediatric. So most people are getting their X-rays back fairly quickly. Obviously, there's always room for improvement, and our hope is that this data gives you an entry into the conversation with your radiology partners and your lab partners in terms of how rapidly you should be getting this data back. And at the end of the presentation, you'll see I've broken down all of this data into some fractals. So what are the highest performing EDs doing in terms of the 90th percentile, 75th percentile, and again, the median displayed. Order first ultrasound, again, fairly consistent across all volume bands at about 100 minutes. So again, typically not going to be a huge drag on the system unless it's ordered late in the visit. And then from an analysis excuse me, from an analysis perspective of what I was able to pull from the data, I would just say no to MRI in the ED. The median time of 4+ hours is too long for ED-based testing. Our mid-volume cohorts are already challenged with throughput into those 60 to 80 and 80 to 100,000 volume bands are typically our lowest performing ERs in terms of throughput metrics because of the challenges they face with space and increasing volumes. Nearly 7-hour turnaround time for MRI is just not acceptable. Other radiology modalities, pretty consistent. I was surprised. I expected it to be far more variable than it was. And even when we're looking at the 90th versus the 50th percentile, the range is not, or the standard deviation is not that large outside of MRI. Ultrasound was that most consistent metric with that variation of 40 minutes. CT results are only 10 minutes longer than a plain film, which I thought was fairly interesting. I don't know why. Obviously, the way radiology prioritizes those readings, it probably has something to do with it. Again, lots of questions arose when I was looking at the data in terms of future study and future understanding based on this first subset of data that we were able to collect. So some best practices that I've seen as I travel the country and visit different emergency departments, pardon me. One of the newest things that are coming out in terms of innovation, as this is an innovations course, is something that has been titled a radiology liaison, or somebody that is similar to a charge nurse in the ER or a patient flow coordinator. There is a coordinator from radiology. These are new positions in higher volume EDs who work at the elbow with physicians for the most part. The role is staffed by radiology and stationed in the ED. And what's their role? They work with the charge nurses and floor coordinators to prioritize those patients and determine who is next on the list. So that if you need somebody to chase down a report for you, this is the person that is able to do that. They're much more familiar with who's reading what. These roles have just begun to emerge, particularly in the 80 to 100,000 volume band EDs and 100 and more, where you're doing a high volume of radiological studies. This role can certainly improve the efficiency and the relationship between the ED and radiology. So then there is the work list. When I have been trying to do some problem solving with ERs and radiology, and we are always trying to figure out if radiology can see our patient list. How do they know who's next? How do we prioritize when we've got 15 exams that are in the queue for radiology? And I would challenge you to start to look at it differently. Most radiology information systems, if it's not part of your main EHR, they have their own work list. And they could, in most cases, it is fairly simple for them to give you access to that work list, sort by the work list by the ER. And then as your patient flow coordinator or your charge nurse, whoever you've got, kind of keeping an eye on the ship in terms of patient flow, can certainly use the comment section of that work list or be able to identify from that work list how to prioritize the patients and let the radiology coordinator or the CT tech or the plain film tech know who you would like to see first, who's ready, who's undressed, who's ready, whose IV is started. All of those things that we constantly hear from radiology about why the ED patients take so long. Certainly could be improved with a system such as this. And then finally, one other best practice here is transport. We don't think about it often outside of getting a patient up to the inpatient bed, but when you think about how many times our patients move from our ER stretcher or ER chair to radiology and back, it's a lot of steps. Any management engineer would tell you that. And since the steps are not going to get shorter for anyone, we have to identify people who are best suited to be taking those patients back and forth. And I hope you will all agree with me that when practicing on top of your license, that should not be a rad tech who is the only person who can, besides the radiologist, who can actually take the film and position the patient. And it should not be a nurse, because the nurse has plenty of things to do and that have nursing tasks. So let's identify some transport and maybe a shared resource from an FTE perspective that are basically people movers. And let's let the rad techs and the CT techs and the ultrasound techs do what they're best at, and that is prepping patients for the exam, completing the exam, and then getting that exam off to the radiologist for reading. And then along those same lines, we are starting to see some radiology ready suites as more and more emergency departments are putting a provider at the front door and ordering immediate radiology exams, and particularly plain films. One of the complaints that we hear are there's no place for a patient to change. If they're in a vertical care area, the whole idea is to keep them clothed and rapid turnaround. And radiology wants everybody undressed so they can get their positioning done and get the image of the body part that they need to shoot. So if you could try to locate some space outside of radiology where a patient can change if necessary, that has certainly been one of the challenges a lot of people have found, but people have had. But if you have been successful in finding some space, that does remove a large bottleneck in terms of patient readiness for radiology exams. And then finally, if you're not already doing this, I would highly recommend that you form a team with your radiology partners, ED physician, one of the radiologists, the radiology coordinator, a tech, some nurses, and monthly you look at throughput issues, establish your target metrics. You can now you've got some idea of what we should be able to track in terms of median times for those four exams. Identify your target times in conjunction with your radiology partners, and start to track those and see if we can't tease those back. Just a caveat quickly: the radiology department typically, particularly the radiologist most often, their metrics that they benchmark themselves with is image available until the read is done. From the radiologist's eyes, their workflow starts when they get an image. But from an ER perspective, there's all that front end time until that image is taken. So please make sure we're talking apples to apples when we're looking at data from emergency or from the radiology department. It definitely is from the time of order, not from the time of image acquisition. And then the high flow strategies. What is high flow? High flow is everything is full. We're backed up everywhere. What are we going to do to pull additional resources to help us get caught up? High flow in the ED comes from multiple different entry points. We get overwhelmed with EMS. We get overwhelmed in triage. Radiology has the same issues. They get overwhelmed with a multitude of films. They have too many CTs. They're trying to drain an abscess on your CT table. Pick your roadblock, and I'm sure it's happened to all of you. But a key would be in that team meeting is to develop, when these things happen, let's have a strategy in place already, so we're not making it up every time that roadblock is identified, and we have different solutions. Have a playbook of what we do when, for what, or how we do things, and make sure everybody is educated to that, so that every day is not a different Groundhog Day. Don't forget, from an ED perspective, that we are responsible for the order disrobing IV starts in most cases, in patient readiness and movement. And how do we streamline that and let radiology know when the patient is identified as ready? And also in this team meeting, we would be a great place to discuss QA for those incidental quote findings. For example, who communicates the 2 millimeter lung nodule on a chest Xray the day after discharge, as one example. All of that should be well articulated and agreed upon in this team, so that we do not have those missed incidental findings, that nothing gets acted upon. So that kind of wraps up our radiology portion of the turnaround time data. We're going to move on now to the laboratory test. And for lab tests, again, we tried to focus on those things that were decision makers. The process was the same in terms of identifying patients to report their median times on. As you can see here, we looked at CBC. I write BMP, that's what I'm familiar with, but whatever electrolyte panel or a basic electrolyte panel that you order in your institution was how that number was defined. The lactate, the troponin, and the urinalysis. Report for all patients with the location is ED, and we'll move right along. So order first result for CBC, fairly consistent. Again, though that under 20,000, the under 20,000 volume band, a high performer in this particular realm. Over 20,000, also high performer in this realm again, but again, not a large N for the over 20,000. And one consideration I thought about when I was looking at this number is, because of the volumes that they have, do they have a stat lab in their department, and do they have a lot of potential point of care testing taking place that our other cohorts potentially may not have? So CBC median time across all EDs, 42 minutes, a little longer in adult and adult EDs. Not surprising, longer in pediatric facilities, because again, it's remember we tracked from order time, not acquisition time. So we all know it's a little harder to get blood out of kiddos. And the rest of that you can just take a look at for yourself. And again, the deviation other than the under 20,000 volume band is not great. 15 minutes either side of the mean. First order basic metabolic panel. Again, the turnaround time highest in those mid to high volume EDs. Excuse me. At 90 minutes for the 80 to 100,000. Otherwise, we're looking at sub 1 hour for that chem panel to come back across the board for the most part. Ordered the first result available for lactate. I was surprised that the lactate was taking this long. Again, 40 to 60 minutes. As the median, I think that there's probably some room for improvement for everybody across the country in terms of getting that result back faster, working with our lab partners. Ordered a result for first troponin. Again, I was surprised that the median would be this long in terms of how we all prioritize that first troponin for the ER. So 60 minutes up to 80, again, that under 20,000 leading the pack. And even that is longer than I thought it would be at 43 minutes. I was surprised we didn't see more 30-ish. And as the MRI is to radiology turnaround times, urinalysis is to lab turnaround times. All over the board, no rhyme or reason in terms of who's doing what when or why. The median time is 77 minutes. So every time you're ordering a UA, we're adding another hour to that patient's length of stay potentially. Certainly a valuable test, but the bane of every ED's existence. It comes up in every one of our innovations conferences. What are we doing, and has anybody solved the problem of the UA, particularly on the acquisition end? Again, all over the board. So analysis, other than the UA, most times we're not highly variable. We kind of talked about that. The cohort size didn't seem to be a relevant factor in terms of speed for the lab as it did for radiology. Troponin and lactate were longer than I would have predicted. Future reporting likely needs to be differentiate between point of care and laboratory results. That certainly has a potential to skew what we collected. And I'll be working with the EDBA board in the coming months to try to identify if that's something we want to break out and report separately, or just carve out any point of care results from the overall median turnaround time, because as you all know, that will certainly skew. And remember, don't throw the lab under the bus. On average, they do okay. They get it right probably 99% of the time. We, as clinicians, we tend to remember that those cases that they don't. But for the most part, they do a pretty good job. And at least I hope they do in your department. Most places I've been, lab is usually not a huge drag on the ED. Along those lines, assume good intent. They're not there to make your day miserable on purpose, but as we all know, it does happen. It does happen. And the other thing I want to point out is that at the end of the day, if you've ever gone down and toured a lab, especially a modern one, they're pretty much automated. You know, once it hits the lab, they spin down the tube, put it on the conveyor belt, and eventually that result spits out. Depending on that result, sometimes they'll have to rerun it for validation and verification. But for the most part, once it hits the lab conveyor belt, we're looking at anywhere from 15 minutes down there for a CBC to 25 to 40 minutes for any kind of chemistry analyte. So the majority of your lab delays are typically on the ED side. I will not discount the lost specimen and the multiple times that might happen in a day. But order to procurement is really always where the majority of process improvement time lies. And that is completely under our control as emergency clinicians. So if your facility is above the median, there's high likelihood you've got opportunity to change that procurement process. And if you're below the median and you have a good process, please share that. I'm sure that everybody on the listserv would love to hear how you're doing things that make your turnaround times so much better than everyone else's. Moving on to best practices for the laboratory, phlebotomists in the ED. I can't stress how important this is in terms of efficiency that I've seen in the last several years. They definitely increase quality and decrease cost. There's far less hemolysis. Labeling errors are nearly eliminated. Your lab will love you if you can agree upon a shared costing model for how we move people to the ED to draw this blood. It allows your nurses to focus on assessment and intervention and education and not lab draws. Typically, your lab volume from the ED in most labs, unless they're doing a huge outpatient business for multiple other facilities, is probably close to 50% of the overall volume that the lab's doing throughout the day. So that's a big lever that you can pull and talking to the lab about, hey, let's get a phlebotomist down here to help us. And labs through IV, it's really no longer considered a best practice. It's a delay on turnaround times, as well as the #1 cause of hemolysis and repeat draws. So if you are still making your overall process in the ED is to avoid that one stick by making patients or by starting an IV and then getting labs, I highly recommend you give that some thought and move away from the labs through the IV. In my experience, patients do not mind getting stuck twice, particularly if you use some scripting that allows them to understand that it's safer, better, and more accurate if we just do a lab draw versus putting that drawing those labs when we start the IV. And patients definitely hate IVs more than they do a straight stick. So that I don't think is up for too much debate, but I'm sure we'll get some comments about, and I always do, nurses disagreeing with that. But I just put that out there as an observation in terms of what I've seen across the country. Consider point of care testing if you're not already doing it for UAs and HCGs. When you consider the procurement time it takes to get the urine in the first place, and then send it to the lab for analysis. Yeah, like I think it was 77 minutes on average. We really should be able to do this in the ER with the machine I'm familiar with is a Clinitech. It basically is a digital reader of the chem strip that you dunk in the urine. We do point of care testing universally for blood sugars. Why not urine in the ED? And if you have that phlebotomist that we talked about in the previous slide, and you can train a handful of phlebotomists that work in your department to be the point of care specialist, that will also help with the argument of lab. Falling back on point of care testing is too expensive and it's too hard to keep people competent. But in my experience, if you've got a phlebotomist or a phlebotomy group that the lab trains, even if you have to pay for them, that's a smaller number of people that are responsible for those competencies. So definitely it's something to consider going forward if you're not already doing that. And then in summary, those were the best practices for lab that I could share with you. The data, as far as we can tell as an EDBA board, nobody's ever looked at this data overall from a national perspective. Any studies we found published were kind of process improvement studies before and after in single intervention in single sites. As I mentioned earlier, it's a good starting point for discussion with your ancillary partners. Share your best practices if you're a high performer. Again, that turnaround time for BMP and troponin, I think we can tease down a bit. I was not expecting it to be as high as it was. And again, say no to MRI. It is just, then it's a drag on the system for everybody. And then in these last two slides, real quickly, I've given you the 90th, 75th, and 50th percentile by volume band for CT, X-ray, and ultrasound, the radiology piece. These are times in minutes reported. Again, it's median minutes for each of the volume bands by modality, and then the same thing for lab. That's there for your reference. We will do questions coming up in the live section here at the end of these recorded presentations. I want to just thank you for your time, and hope you found this information valuable, and look forward to your questions. Thank you very much.
Well, look, I don't want any of us to be dirty capitalist pigs as far as our practice of emergency medicine goes. But as my good friend Mike Granovsky always says, no money, no mission. And so all of you want your departments to stay afloat, and it's been quite difficult, hasn't it, during COVID? And he's going to share with us some of the new tips and tricks in terms of billing and coding and documentation. Nobody knows more on this subject than Mike Granovsky, and we are so glad that he could join us today. Mike, thank you so much for being part of the program.
Shari, thank you for that warm introduction, and welcome to 2021 Reimbursement Update. We're going to spend the next 20 minutes in a rapid fire fashion looking at the way we're paid this year in 2020, and then getting a little bit of a lens into 2021. The RB-RVS equation that's been in place for the last 20 years still governs our reimbursement paradigm. We take the work RVUs, the practice expense RVUs, and the liability insurance RVUs, add them up. They give you the total RVUs for a given code. Then the really key formula at the bottom of your slide, take those total RVUs, and our RVUs in emergency medicine, we have good news. They are going up from 2020 going into 2021. Those RVUs for our codes get multiplied by the conversion factor, what Medicare pays per RVU. And as we'll talk about in greater detail, there's some downward pressure for complex reasons on the conversion factor. Those two items, the RVU total and the conversion factor, they're multiplied together and they give you the Medicare payment. We've been making the argument to increase the ED RVUs for several years. And here's a quote out of actually last year's 2019 Physician Fee Schedule Final Rule. Quote, "We agree with the majority of commenters," this is CMS stating that they agree with us, "that ED services may be potentially misvalued given the increased acuity of the patient population. We all know our patients are sicker and more complex." Now, we seized upon a strategy that goes all the way back to 1997, when there were historic statements by the RUC, the Relative Value Uptake Committee, that stated that the ED codes 99281 through 99285 should have a parity relationship, some sort of proportional relationship with the office visit codes. For other reasons, the office visit codes are going up very substantially in 2021. So we hitched our wagon strategically to that concept of relativity and made vigorous arguments to CMS that since the office codes were going up, the ED code should go up as well. Quote, the American College of Emergency Physicians submitted commentary with a specific recommendation for CPT codes 99283 through 99285. The association believed we should continue to preserve the same relationship between the ED and office E&M visits, what they call relativity, that was established in prior years. And again, that's going all the way back to 1997, reiterated in 2007. And CMS said, we agree with the society. That's out of the physician proposed rule that was released on August 4th of 2020. And as a result, our RVUs are going up. So 99283 work RVUs going from 1.48 up to 1.60, a 12.68% increase. Very good news. 99284 going up 5.38%. 99285 also a little bit more than 5%. And we've modeled this for a number of groups, whether you're an academic shop, a community group, or varied urban rural practice settings. Typical group will see an E&M distribution with those level 3s going up 12%, level 4s going up 5%, level 5s going up 5%. You'll see an increase of about 0.2 RVUs per patient. So if you run about 4 RVUs per patient, you'll now run 4.2 RVUs per patient. And that cuts both ways. If you're paid based on RVUs, pay will go up. If you have expenses in a department budget based on RVUs, those expenses will be going up. And just so you have a complete set of reference material, I've included the component detail in the slide here. We can look at, for instance, 2020 99283, just reiterating in bold on the left side of your slide, 1.42 work RVUs for 2020, going up to 1.60 for 2021. Then on the right side of your slide, 99284, looking at the total RVUs, where we take the work, the practice expense, the liability insurance, add them all up, going from 3.38 up to 3.57. 99285 going from 4.91, broaching that 5 RVU barrier, up to 5.18 RVUs. Now, I already mentioned that the office visit codes were part of our strategy to raise the RVUs for the ED codes, but that there were also some unintended consequences related to the conversion factor. The office visit codes are going up, and they are used so frequently, they represent 20% of total Medicare physician costs, that they're moving the entire needle based on the Medicare budget. In addition, there's another code that the office folks can use for complexity that's a little less than a half an RVU. The statute, which will go into the weeds because this is a key linchpin item, states that budget neutrality needs to come into play if an increase in expenses exceeds $20 million. The office visit codes going up, since they're used so frequently, has triggered this budget neutrality process. And what happens in budget neutrality is RVUs can go up, but then the conversion factor is brought down in order to maintain budget neutrality. And the office codes are going up a lot. And that's what's triggered this budget neutrality process. We saw this coming and commented last year. You can see at the bottom of the slide, quote, many commenters expressed concerns about the redistributive impact of revaluing of the office codes, particularly for practitioners who do not routinely bill those E&M visits. That's out of the CMS Physician Final Rule last year, page 888. We don't bill in the ED, the office codes. If you're running an urgent care center, you do bill those codes. So let's get down into the weeds of the regulations because this is a big potential hit. So it really is worthwhile investing a little bit of academic energy to understand it. The budget neutrality concept comes actually out of the Social Security Act. Section 1848 of the Act requires that increases or decreases in RVUs may not cause the amount of expenditures for a year to differ by more than $20 million. If that threshold is exceeded, we make adjustments to the conversion factor to maintain budget neutrality. So on the left side of your slide, you can see the historic conversion factor, 2018, 35.9996. 2019, we broached $36, 36.0391. 2020, $36.09. And 2021, because budget neutrality has been triggered, the conversion factor is being depressed 10.61%. So we're going from a $36 conversion factor down to a $32 conversion factor, specifically because the office visit codes have driven the overall Medicare cost way past that $20 million threshold. I've got Table 88 out of the physician fee schedule proposed rule, budget neutrality minus 10.61%, very formal, 32.2605 is the proposed conversion factor. So we've got the ED RVUs going up. That was very strategic. But unfortunately, because of the office codes, we've got the conversion factor going down. We will have good news, though, by the end of this talk, I promise. So the conversion factor decrease, who is impacted? It's very important for us to understand who are our allies in the House of Medicine and who is benefiting from these changes. Well, the cognitively intense specialties, they have office codes that are really going up, 25, 28, even 30%. Hem-onc, endocrine, allergy, immunology as examples. Our allies are folks who don't bill the office codes. Surgery, pathology, interventional radiology. CMS estimates that they'll go down minus 9%. Very big hit. Intensive care medicine, anesthesia, nuclear medicine going down 8%. So let's slow down as we look at the bottom of the slide now. Net impact for the ED, conversion factor in RVUs, because the ED is projected by CMS, and I don't totally agree with their projection, to go down minus 6%. So I said in the beginning, our RVUs were going up. 4 RVUs per patient, going up 0.2 RVUs. We'll use the metric of percent because that makes it easy in apples to apples discussion. So our RVUs for a typical group going up 5% on the low side, probably as much as 6% for some groups. So we're plus 5% on the RVUs and we're minus 10.6% on the conversion factor. That gives us a minus 5.6%. But that's for the Medicare component of your patient population. It's not for all of your patients. So it's applied for most groups to about 1 in 4 patients, about 25% of the payer mix. Well, if you have a minus 5.6% applied to 25% of your payer mix, you'd be going down 1.4%. So you may hear in the lay press, oh, things are going down minus 6%, minus 10%. In the ED, our Medicare patients might be going down minus 5.6%. That's only 1 in 4 patients. So for our whole book of business, only going down 1.4%. Now, it's important to realize that you may have contracts that have multi-year anniversaries. They might be 2, 3, 4, even 5-year contracts. They may reset occasionally. They may reset according to Medicare rates. So if you do have contracts that are resetting according to recent Medicare rates, then there would be some headwinds with other payers. But again, we're going to have some good news. What are some potential remedies to this proposed conversion factor decrease? Well, it literally is going to take an act of Congress, but we think an act of Congress is possible. So the conversion factor changes, they're not under the auspices of CMS or even the whole agency, HHS. They're literally decided by Congress. Obviously, the optics of a 10.6% decrease during the COVID-19 pandemic for frontline providers are terrible. And it'll be very unfair as we're all balancing staffing, lower volume, higher acuity, mental health issues among our providers to then be slashed while we're literally in harm's way, exposing ourselves and our families to COVID, to be cut 10.6% really would not play well. And I don't think it would play well even with the public. So what are some possible remedies? Well, Congress could kick the can down the road. It's just sort of it's a little bit of a gutless process, but they could not repeal it, but they could say, well, we're going to phase it in over 5-6 years. But for the first 5 years, the phase in is 0. And then we live to fight another day. And we continue to advocate, and who knows what will be in 5 years. There could be a formal budget neutrality waiver during the public health emergency. Wouldn't that be nice? That would actually make sense to me. They could hold off on implementing that one little code I mentioned, the complexity code, which the office folks can use, which generates half an RVU for a lot of the office visits, a very high percentage of the office visits. That would take the ED's minus 6 down to minus 3. And again, that's for 1.4% 0.4%, or about a quarter of the patients. So that would be reduced even further. There was a very significant advocacy effort underway. You can hit the link at the bottom. It's a fairly slick landing page. And if you want to express your dissatisfaction with a 10.6% cut in the same time that we have this national pandemic going on, then absolutely you can express your opinion there. Net, inside the Beltway, we're really thinking that the optics are so bad that there will be a solution. So what could happen? The EDR views, they're going up. They're going up 5-6% for most groups. The conversion factor, well, if the conversion factor, they got rid of the complexity code, that would be a -3%. So we'd probably be positive. Or the conversion factor could be stabilized at $36. Then we'd be up 5 or 6%. So if I were making a budget right now, knowing that I'd probably have to redo it when the final rule comes out, probably around the holidays, and then this conversion factor argument, which will probably spill into January, I don't think that I put a -6 in my budget unless there were very strategic reasons to do that. Net, we'll probably see a small increase. And I'm really hoping that that's the case. We certainly deserve it. We're going to pivot now and talk about telemedicine. Telemedicine has obviously expanded greatly during the COVID-19 pandemic. Entrepreneurial and resourceful ED providers are finding ways to interact with patients that keep both providers and patients safe, decrease the amount of PPE required, and still deliver excellent and high-quality care. So in order to understand the impact of telemedicine during the COVID-19 pandemic, we need to pull the lens back and figure out where were we in the emergency department with regard to telemedicine pre-pandemic. So pre-COVID, the 99208X, 99281 through 99285 ED services, they weren't on the CMS list of covered telehealth services. So they really weren't billable through a telemedicine encounter. There were some funky ED inpatient consult codes. They were really for the neurology or neuropsych specialists beaming into the ED. And we had some G codes for those, but they weren't really for us bedside ED providers to bill using telemedicine. And then there was a small fee of $26.65 that the facility got to wheel the robot into the room, $26.65. So there were 4 major changes very quickly in March and April that really liberalized the use of telemedicine on a temporary basis during the public health emergency. Number 1, both the ED and the OBS codes were added to the approved telehealth list. And for those running multi-site OBS programs, where you have 2, 3, 4, 5 hospitals involved in OBS, some groups are using a mid-level provider rounding in person, overseen by an attending who's remote by telemedicine. So that's just an added little bonus fact. 99281 through 99285 added to the approved telemedicine list. CMS 1744 is the transmittal, and it's page 19 out of 221. They made the billing very easy. We can use the ED-specific place of service, which is place of service 23. That just means that claim is going to go out. It's going to look fairly similar to a typical ED claim. There's nothing special really required for the processing, and our experience is they are getting paid. Number 3, we have pay parity for those ED telemedicine services. So it's one thing to say that telemedicine is covered. It's another to say it's covered and it's paid at the same rate as if you saw the patient in person. And that's that same very important transmittal 1744. And then the last point, the 4th point, I'm going to slow down on. On-site technology-enabled visits, those are just regular visits. So if the doctor and the patient are in the same location in this case would be defined as, for instance, hospital campus. If you're on campus and the patient's on campus and you use some technology for part or all of the visit, that is just a regular visit. That is not a telemedicine visit. So there's no special processing. It's just a 99284, 99285 visit. Quote, services should only be reported as telehealth services when the individual physician or professional providing the telehealth service is not at the same location as the beneficiary. That's CMS Telehealth FAQ number 15. So how do we document for these telemedicine visits? You want to document in the same manner as if you were seeing the patient face-to-face. There's no special documentation exclusion for telemedicine. The rules are the same. HPI, past family social history, review of systems. Those are all just through a telemedicine interface, like if you were having a FaceTime visit with one of your family members. You perform a visual physical exam. You can usually get 5-6 systems visually if they're relevant. Some folks are being very industrious, using the patient's Apple Watch, including vital signs, even including EKG tracings at times. I've seen a number of charts like that. And then medical decision making, again, the chart is scored the same as if you were seeing the patient in person. So differential diagnosis, including any concern for COVID, prescriptions, testing, self-monitoring instructions, etc. So what does the future look like? So right now, ED 99281 through 99285, gangbusters, telemedicine, we're all set. What happens when the public health emergency ends? And right now, as we sit here taping this lecture, which you'll be viewing probably in the beginning of December, the public health emergency was just recently renewed. And it looks like because of this third wave, will probably go on well into 2021. But what happens when it ends? Well, CMS on August 4th released a proposed rule which talks about the future of telemedicine. And they're proposing to keep the ED codes at the lower levels, 99281 through 99283, on the approved telehealth list for what they're saying, quote, the remainder of the year after the public health emergency expires. So for instance, if the public health emergency, which is a very technical formal designation by the Secretary of Health and Human Services, ends in February, the ED codes will remain on the list of approved services for the remainder, March through December of 2021. That's giving CMS 2 rounds of rulemaking to make that change permanent. And this is CMS telegraphing their great interest in making those changes permanent. However, they are proposing to remove 99284 and 99285 from the telemedicine service approved list, stating we are concerned the full scope of service elements of these codes, these higher level codes, cannot be met via two-way audio video telecommunications technology. If your institution has a use case for 99284 and 99285, for example, a mothership tertiary care level 1 urban trauma center that's providing consultative services via telemedicine to a rural center, probably an H485 visit, then you should employ that scenario in your advocacy efforts. And if your institution interacts directly with CMS, please share that use case. If you need an avenue to access CMS for that commentary, my contact information is always the last slide in these lectures, and I'm happy to put you in touch with the right folks who interface with CMS on a regular basis. Now, what about teaching physicians? We've got a large academic audience. Well, telemedicine has been very sensibly deployed during the public health emergency. Teaching physicians can now meet the supervisory requirements using telehealth during the public health emergency. Does not need to be in person. The requirement for the presence of a teaching physician can be met through interactive telecommunications technology during the key portion of the service. March 30th, CMS IFR page 103 out of 221. So you've got the citation there for your institution if you get any pushback. So you can meet that key supervision requirement through telemedicine. Very key. What does the future look like with regard to teaching physicians in telemedicine? Well, it looks pretty good. Teaching physician telemedicine oversight may be extended beyond the public health emergency, and CMS has provided 2 little tells that they're very interested. They have both said that they would extend it until the end of the year in which the public health emergency ends, and that they are soliciting comment. When they solicit comment, that means they're very, very open to things. While we have concerns about extending our interim policy regarding the virtual presence of the teaching physician, we believe public comment would be helpful. When they say that, they really want commentary. They're very open to maintaining teaching physician oversight. And that wasn't specific to any particular code set. That could be 99281 through 99283, 99281 through 99285, something else. And we are considering extending our policy until the end of the calendar year in which the public health emergency ends. Again, if the public health emergency ends in February, that gives CMS 2 cycles of rulemaking to make these changes permanent. So please, if you're an advocate for the use of telemedicine in the teaching physician setting, this is an open door. They're literally asking for commentary. Please submit commentary. So some conclusions. Our views are going up. So typical group is going to go up 0.2 RVUs, 5% or 6% increase. I went through the conversion factor challenges in great detail, but again, if all they do is eliminate the complexity code, we'll be up a couple percent. If they make the conversion factor budget neutral, we'll be up 5 or 6%. We're really hoping for a good outcome. And it will likely not come during the physician fee schedule final rule in December. It will likely come through an act of Congress post-election in January. Telemedicine is growing. It's growing in the ED service area. It's being used very sensibly by teaching physicians. And let's all remember, we should be very proud. We've been the safety net of the U.S. healthcare system for years, but now we are also the tip of the spear. My contact information is here. I interface with folks by email throughout the country on a regular basis. I just ask that you give a little bit of context. Hey, Mike, I heard your ED innovation lecture and I have a follow-up question. Thank you very much.
Well, if any of you listening have ever attended any of our ED innovations courses, by far the most popular part of the program turns out to be a section, it's a workshop called Nurse Leadership Struggles. And Pam Turner has been a nurse executive. She's been in over 28 emergency departments when she worked for HCA. So this lady knows a lot. And she's also excellent at helping coach leaders. That's something that she has done in her past. So we asked her to put together a little program about nurse leadership struggles. As I say, it's been so popular. In fact, we've had many physicians attend that little part of the course. So physicians, you're welcome to stay tuned. I'm sure what she's going to tell us is very important. Pam, thank you again for coming and sharing this and putting this program together.
Thank you, Shari. So good afternoon, everyone. As Shari said, I am Pam Turner, and I have been an emergency department nurse leader for well over 20 years. Today, I'm going to talk to you about the struggles that ED nurse leaders are currently having in this environment. So as ED nurse leaders, we are used to having all these different boxes that this diagram shows. We work what tends to be a lot of chaos, and then we have a lot of systems that we have to work with. And then the different management theories, both democratic, authoritarian, and then the bureaucracy. And this comes from both within the hospital organization or our system, and then outside to our partners that we work with. So we're going to talk a little bit today about some of the struggles that you're having and some ideas that I found from talking to nurse leaders across the country of how they've overcome these things in the last few months. So we're going to talk about the nurse leadership during the pandemic, some operational considerations, and then how do you maintain that high quality patient care in this type of environment? So leadership strength, this is something that will be very trying to many nurse leaders, depending on your level of experience. But one of the most important things that you can have as a nurse leader in this environment is transparency. You have had to make a lot of tough decisions over the last few months, and you will have to continue to make these tough decisions. So be transparent with your team as to why the decisions are made, because this will let them know that you may need to make changes in the future because you made these tough decisions sometimes in a very short time period, but you want to be able to go ahead and explain why you've done that, make the best decision with the information that you have on hand at the time, but by being transparent, your teams know that you may have to change it, so they'll understand that when you have to change it, maybe in a week, in 2 days, whatever the case may be. And then accessibility, leadership accessibility is very, very important. And so how are you accessible as the department lead to your team, either as a director, manager, or a VP, but how is the rest of your nursing leadership available? So in order to make sure that you're having a work-life balance for your leadership team, schedule people to be available around the clock 7 days a week so that if something comes up, there is a leader available to take care of that. That will help your workforce feel like they're being heard. Communication. Make sure that your communication is frequent. How you use that, again, we're going to talk a little bit more about how to communicate, but do you have consistent messaging? And this is very, very important, not only among the nursing leadership team, but with your physician leaders too. So you need to make sure everyone is giving that same message out, because that will help minimize any confusion as you're making constant change in this environment. And then timely communication. What I mean by that is if you put a process in place yesterday, but you didn't communicate it till today, that's not timely communication. Always give the communication prior to implementing something. Even though you may have to implement it in the middle of a shift, let them know, do a quick little shift huddle, let them know what's coming, and then make sure that you're letting the team coming on know the changes. And then let's talk about a little bit about workforce and patient safety. You want to make sure that you're conveying expected behaviors for the safety of your workforce and your team. So as you've developed these processes, you should be putting into place through your communication that this is expected behavior and all staff needs to follow this. But one of the things that many leaders struggle with is accountability. Is you put forward the expected behaviors, but when someone doesn't follow it, what is that accountability? And that's one of the biggest dissatisfiers I've seen going across the country with our team members on this. So have expectations and accountability built in to whatever you're doing today. So team communication, departmental leadership meetings. So this is where it will be very important to make sure you have the right leadership team, and that may include your physician partners, or if you have medical students, it might be part of the teaching teams coming in and being part of your leadership meeting. Talk about what changes are occurring, what needs to occur, and any challenges that the team is having. Bring that entire team together. Then from that, you're going to develop your team communication. How are you going to communicate that? Is it going to be in daily huddles, in shift huddles? And you want to make sure that you're having enough shift huddles that it gets everybody coming in those off shifts. Is it through emails? Is it through texting? A lot of this can now be set up very easily to do group text and group emails. One of the things that are really up and coming is the video conferencing. And so people are able to join into a video conferencing such as Zoom, Microsoft Teams. There's just a lot of different platforms out there depending what your hospital is using. But you can record that first conference, and then your team can come back that may be at home sleeping. They can then listen in of what was said. This is generally used for more detailed explanations of maybe a change. And then phone briefings are meant for very short briefings, bringing people up to speed. Again, can you record those phone briefings, and then someone can access that later. SharePoint sites are a great way to keep all this information in, and then they can access that. Hospital-wide communication, virtual town hall meetings are really very occurring at almost every institution now. And so it's having that virtual information, recording that so people can listen to that. Monthly educational virtual updates and electronic educational toolkits. So as all these changes are occurring, results almost always in some kind of education that we need to do to our team. Can we do this virtually, record it, and then the team can access it? However, you want to make sure that it's easy to get to. So if it's overall, all of nursing needs to know this, it goes into one folder. If it's ED specific education, maybe in another one. We want our team to access this information very easily and timely. Encourage innovation. This is one of the things that has exploded across the country, is ways that use your team, their experience, their creativity, even our new team members. They see things in our department that when we've worked there for 5-10 years, we don't see. So let them help you develop ways to do teamwork, new teamwork in this environment. How do we continue to give high quality care and have good patient experience with all the challenges our patients find themselves in when they come to our emergency department this day? They're all alone, they sit in a room, they have no distractions. How do we get that all engaged? Safety procedures. Again, what is some of the best ways to do safety procedures, and how to use technology? Some of our younger workforce, they can help us understand our technology. How do we communicate with each other and communicate with our patients and maybe the rest of the care team? So just let them loose and get them engaged in that. So To overcome some of these operational challenges, emergency departments that have been very successful in the past has done this through structured processes and geographical planning. This is so true today. If you have great structured processes and understand how best to use your physical plant with the environment and type of patients you're seeing, it will help you maintain order and be able to see more patients and have a safer work environment. So departmental processes, we're going to talk about intake and screening, the surging of ED and non-traditional treatment areas, along with the hospital operational changes. Is there a surge plan that we have had when they've dusted it off that we've had to have to meet regulatory compliance? Is it really going to meet the needs of this COVID-19, of a pandemic? And so again, what changes have we made to that? Do the right people sit on that team? Cohorting is another big challenge. How do we cohort these patients, both in the inpatient side and in the emergency department? How is the inpatient side using telemedicine and the inpatient outpatient settings? Are we using it to its fullest extent that is allowed within your state? And then regulatory compliance. How do we meet regulatory compliance in this day and age? So strategies. To do all of this, you have to have a strategic plan to change management. And sometimes that's very foreign to us as nurse leaders. But understanding that you have a strategic plan of how you're going to implement change is going to allow you to pivot quickly. Involve the right stakeholders from the beginning. It will save you time of having to go back where you've designed something that is going to impact another department, thus causing unintended barriers to your throughput. Design a solid tier communication plan. So where we started and we peaked, maybe your state peaked and now it's come down and it's going to go back up. If you have a communication plan to say, if this occurs, if X occurs, we're going to communicate to who are we communicating to, when are we going to communicate to them, and how. Are we using, again, texting? Are we using emails? Are we using different, oh, my mind just went blank. If we're using, it went away. So, but the different technologies, how are you going to do that? That's going to be the key to this. Patient and family communication. Maximize your technology to your families. One of the best things to do that I've heard from some of the departments across the country is telephonic communication. If some of your departments have phones in the patient rooms, make sure the patients can reach those easily, and then use that phone to communicate. So if a patient has a call bed, you go in and then you go in and you can stand at the door, but you want to minimize the times you're going in and out. So if they just want a warm blanket or they want water or they want their meal, you want to minimize that so you can identify their needs outside of the room and then go in. This increases the efficiency of your work team, and it increases communication to the patient, which they so sorely need in this day and age. Video conferencing. Bringing our family members in. So when you need to talk to the family members with the patient, if you can three-way video them in through the different platforms that you have, that's great. This is, again, a time saver for your staff, because instead of talking to the patient and then talking to the family, you can bring them all together and communicate to them at the same time. Telepsych assessment. This is one of the ones you really need to look at is, can we provide telepsych assessments before they come to the emergency department? Can you work within your community and develop a process around that? Telehealth triage. I've been a big component of telehealth triage for well over 10 years. And this is something that you can be looking at so that if they have that prior to arrival, you can then make sure that they're going to the right patient stream as when they arrive. So decreased patient volumes, we're seeing that across the country. As I talk to people, we're seeing those volumes. The volumes are almost always related to low acuity volumes are not coming back to the hospital at this time. They're still using the urgent cares or freestanding EDs, but they're not coming into the hospital ED, which is resulting in an increased patient acuity. So how are you working on that? How is that impacting your staffing levels and the staffing modules that you use? You're going to need to work with your senior leadership team and your financial team to really delve down into that patient acuity of what you're seeing to make sure that you're providing that safe care. Inpatient capacity is another one that has been a challenge, which is impacting the inpatient flow. So physical plant changes, we're going to talk a little bit more about that. So we want to bring the patients in linear. So they're going to come in linear. We're going to do the COVID testing, all the COVID questionnaires that we need to do. And what's happening is some hospitals are using their lobbies because they no longer have family members in there. And then what they do is they're converting that to a patient intake area. And they use the heavy plastic zipper dividers, which can be easily cleaned, but you can still see through them. And then you move the patients through in one stream going forward. They then would go into either the right or left, and depending on what their needs are, maybe a lot of hospitals, all patients that come to the hospital are going to go through the emergency department intake to do the COVID testing before they're allowed upstairs. So this is, again, a great use of our lobbies. Cohorting of patients. How have you had to change your physical plant changes of cohorting of patients? This is not only in the ED, but on the inpatient side. But in the ED, we usually only have 1 or 2 negative pressure rooms. Some of our hospitals don't have any. Now, all of a sudden, you have to have negative pressure rooms. And so you're bringing in these module devices that are very large, cumbersome, hooking them up. They're not meant to be in that area. It decreases your space. And so how is that being used? And then again, looking at your geographic zones. Are we using that the geographic area that you have, that footprint of your department, to the best of its ability? But you also need to be willing to change that. What you did 3 months ago is probably different than today, and is certainly going to be probably different 3 to 4 months from now. So inpatient holds. There is an increase in inpatient holds in the department as I've talked to people across the country, and that's really due to the decrease of available staffed beds. Most of the ED leaders, nurse leaders I spoke to said they're not having a decrease in their ED staff, but what they have found interesting is on the inpatient side, there is a lot more staffing availability up there, is that they're just not available anymore. And so they have all these open vacancies on the inpatient side, which then means that you're going to have more holds in the ED. So the recommendation to the inpatient world and any administrators that we have participating is approach this as the ED would. We have done this for years in the ED. When we look at our processes, is we break it down into segments. So we look at the intake processes, the treatment processes, and discharge processes. Intake and discharge are some of the easiest. Looking at what can you take away? What is the excess? Is wasted time. Take that away and really hone down your intake. Discharge process is probably the easiest one, and one that I recommend that they should be looking at. If an order is written at 9 a.m., you should no longer be having any expectation that it is okay that the patients go home at 3, 4, or later in the evening. That is not okay. So processes need to be honed. It should be, the goal is from 2 hours from the time the order is written that the patient would be going home and is leaving the room. We no longer can have discharge lounges, so the processes have to be tight. And the team has to work together on this to make this occur. But again, this is discharge planning, and we should be doing discharge planning from the day of arrival, and then involving our patient and our family members so they understand that the patient that's discharged at 9 a.m. is going to go home at 11, so that they're there to pick them up. So this is all very structured processes, as we talked at the beginning of this lecture, is we in the emergency department, if we're successful, we have structured processes. And all we're doing is saying if the inpatient units have structured processes to their each individual unit, they will be successful at this. So maintaining high quality. Providing staff education in this COVID-19 environment. We're going to talk a little bit about that, and then a little bit more on regulatory compliance. So be creative in the ways that you provide staff education. Do virtual coursework, and then you can record that coursework. Do the first one virtually, record it, and then it is available to the rest of your team that needs to take that particular course. And this can be available to all levels of your staff skill mix. But then what you do, there are some skills that you do have to check off in person. And with those, we've in the past had these, skills labs day. and they may last a week, and then every day we do different skills, or maybe we just do the whole skill lab for the whole hospital, and it's done for 5 days, 8 hours a day, and people sign up for that. But there could be a lot of people showing up. Now we can no longer have all those people, so you're going to have very short periods. People come in. If they don't show up on their scheduled time, then they would have to reschedule. And so all of that can be done and can be worked. You just have to be creative in order to provide education to our team, but it's going to be very important because there is so much staff education that needs to be done. And then look at ways to cross-train staff. There may be hospital nursing staff that it can be cross-trained in other areas to help where there may be a shortage of nurses in another area. What is the best way to be creative in cross-training that staff? So regulatory compliance. I put this in here because as a nurse leader, you are required to do regulatory compliance. And you need to maintain regulatory compliance even in this COVID-19 pandemic environment. So how are you doing that? But then I want to talk a little bit more about the COVID-19 regulatory compliance. As of October of 2020, there are 25 daily data points that must be reported. And this is around the hospital information. So it's going to be around testing, around any deaths that occur, positive tests, negative tests, your bed availability, who's been discharged today. All of that is within that 25 data points. The next one is the weekly reporting. This is much more around your equipment and supplies. So how much PPE do you have available? What are your available ventilators? Your supply chain availability and pharmaceuticals. And really what they're looking for here is, and this is the CMS COVID regulatory compliance I'm talking about, is do you have 3 days on hand? So if there is a break anywhere in any of these areas for supply chain distribution, do you have 3 days to maintain and provide safe patient care given your current environment? All of this is going to be very important because most of this is going to occur in the emergency department. So who is reporting this? How are you reporting it? Does your EMR allow you to have a lot of these data points? Have those data points been turned on? And so it's not always easy to add another data point to an EMR, and that can take time. But what are you doing as a nurse leader to ensure that accurate data is reported either daily or weekly? CMS came out, and this is their enforcement process that went into place October 7th of 2020. So beginning on October 7th, initial notification of non-compliant letters are going to start going out to hospitals, or already have. Failure to meet those requirements will continue, and on the third enforcement letter, the hospital will receive a notification of potential termination, which then puts the hospital on a 30-day track to become into compliance. If they're not unable to come into compliance, they may lose their Medicare status. And so with CMS, so that's a pretty difficult thing. So the more that you're aware and have good process of is up front, that will be very important. Now, on October 6th of 2020, the American Hospital Association sent a very strongly worded letter out to CMS on how they were opposed to this enforcement process, because there are many hospitals across this country that are struggling with the reporting of these requirements that CMS has put into place. So kind of to wrap this up, just departmental success really comes about us working together as a team. So Henry Ford said this, and I thought it was so fitting in today's, is as a leader, we need to bring everybody together. That's the beginning of our journey of success. Keeping everybody together is very, very hard. And that as a leader is what you need to do. A lot of what we talked about in the first part of this of keeping our team together and moving forward is progress. But your success is when everyone works together. And that is over the long term. So they may very shortly work together, but as this has strung on, is your team continuing to work together? So I would like to thank you for your time today. Here are the references that I have used throughout this lecture. And here is my email address if I can answer any questions that are not answered during the question session later today. Thank you for your time and have a wonderful day.
Okay, everybody ready? You ready, Rick? Okay. And so 3, 2, 1, we're going live.
Hello, everybody. Shari Welch here with the best Brady Bunch ever. I've got all of our faculty here for a little Q&A. You've been submitting some questions, and so we've got a lot to talk about in the next half hour, 45 minutes. So I'm going to just start right in, but let me also put this little plug in. If you've liked this course, we do live courses. Many of you, I hope, have attended our programs before. And in November 15th to 17th in New Orleans, we're going to have the best ED innovations ever with many of the people that you're seeing in this Brady Bunch screen. And we hope that you'll join us. It's going to be a lot of fun, and we'll all be energized to be in person again. In any case, in case you didn't know, you are in a classroom of about 205 people today. And I wish that you all could meet each other. Maybe you will at the next conference. So let's start out. One last housekeeping thing. If you want to get CME for this program and you've been listening to it, you are to submit your name and title to September@benchmarking.org. September@benchmarking.org. Mike, did I get that right?
September@edbenchmarking.org.
Sorry. Thank you. Thank you. Anyway. And feel free to reach out, and you can get some CME for the time that you spent today. All right, let me take a question right out of the chute. Jim, this would be for you. Will staff be able to quit wearing PPE after they receive a COVID vaccine? We've all enjoyed wearing that gear, haven't we? So.
And my quick answer is, I'm sorry. At the beginning, we will not be able to shed our PPE. No more than after you received a hepatitis B vaccination that you would consider shedding your gloves in doing bloody procedures. At this point in respiratory care of patients, particularly those at risk for COVID, we will continue to need our N95, our eye protection, our gloves. Hopefully, we will find out over the ensuing months that we do not have to have the high-level PPE on anymore, but at the beginning, we will certainly need to.
So we need some designer PPE, my friends. If we're in it for the long haul, right? Why not? Mike Granovsky.
We should be lucky to have any PPE.
Yeah, there you go.
That's the way many people feel right now.
Yep. Mike Granovsky, here's a question for you from our audience. I hear that the coding for office visits is changing in 2021. How does this impact ED documentation and coding?
Yeah, great question, Shari, and thanks very much. And I hope folks had a really good experience during the sort of simu-live portion of the course. And I've gotten some nice feedback already from folks. So thank you for that. So in 2021, January 1st of 2021, the office codes will be scored based on medical decision-making or time. The history and physical exam will actually not contribute to the coding. There's lots of reasons why you might document a full history and exam. There are other folks that look at the chart for clinical quality, medical legal mitigation, but from a billing perspective, history and exam won't count for the coding of the office codes. The ED codes are not likely to change, we think, until 2023. And the emphasis when the ED codes do change will be on medical decision-making. And in the 2021 CPT book, there is actually a brand new grid of medical decision-making for the office codes. And we think that the ED medical decision-making grid will be very similar. So 2023, big changes coming for us.
Oh my gosh. To our listeners, did you hear that? We are finally going to get away from all of that tiresome minutia that you had to put in the chart just to get a reimbursed. Yay! This should be the happy dance for everyone. Okay. Hey, Nick, I'm going to give you the question you've been waiting for. Why should someone join EDBA?
Well, everyone should be part of EDBA, but EDBA has the metrics, and better metrics mean better data means better operations. The EDBA is a membership organization of like-minded people who've been interested in ED operations for the last quarter century. There's no politics, there's no profit motive. It's just people thinking about operations, sharing data, and making it work. Now, we have roughly 20 to 25% of all the EDs in the country are members, and we represent close to 35 to 40% of all ED visits. So the database, while it's technically, for research terms, a convenient sample of volunteers, the sample size is so large that it's truly representative of the entire US. And so if you want real data to talk to your administrators about, to judge how you're doing in your department, stuff that's useful to you, that's what the EDBA has. So again, shameless plug, everyone should be an EDBA member.
You know, and I can chime in mind, I'm not a member of the board or part of EDBA anymore. So I'm just saying this as an impartial observer. The listserv is probably one of the most incredible things that you offer, the chance to go and put a question out to colleagues across the country. And usually within minutes, you have an answer from somebody else. Maybe it's how to solve a problem. So look into us, look them up, EDBA, great organization. All right, so Mike, you're the keeper, you and Jim are the keepers of the data at EDBA. How many facilities were in the sample size for the turnaround data that you presented in your talk?
Great question, Shari, and thank you. This was the first year we presented this data and the first year we asked for it, actually. It was, and we did it because so many people were asking for it because it's not readily available out there. Of the, I think, almost 1,100 hospitals that we had in our sample size, which included freestanding EDs this year, about 35% responded with radiology data, and about 25% responded with lab data. So the N for the radiology data was about 320, and for lab it was about 270.
And that's probably one of the biggest ones. I know that there's a couple of other organizations that have done this. But they've been much smaller samples. So this is a great start to get at some of that data. And oh, by the way, you folks, if you're looking at your Brady Bunch, up in the right-hand corner is my good friend, Rick Bukata, who's joined us from California. As you know, he's been our partner in this program. This is sponsored by EDBA and the Center for Emergency Medicine Education. So thanks for joining us there.
My pleasure, guys.
Yeah, we love having them. And by the way, folks, chime in at any time, even though there's questions directed to certain people, feel free to just be a chatty Cathy if you would choose to. Pam, we got a question for you about how difficult it is to sort of keep your staff updated on everything. Things are changing, especially with COVID. What are some of the best communication methods that you've seen? How are people reaching out and keeping their staff in the loop?
Thank you, Shari. Yeah, that's a great question. Tried to cover that in the talk, but there's just so many different ways that people are doing it. But some of the most popular ways is starting to have the video conferencing. So that's one way, and that's being used much more around larger items and a longer meeting. And then the other thing is utilizing text, emails, and then they also, some of the people are developing, depending on the technology within your hospital, but you can almost have your own listserv, if you will, within the emergency department, where you can fire off questions to the right, whether it's a physician leader question or nurse leader question, or for both. And then that way you can ask those. And then also just kind of to talk about some of the old-fashioned ways that work really well is that we did when I was first in the emergency room is our communication binder. Because there's been so many changes operationally over the last few months, is having that communication binder and that communication bulletin that you can keep up to date. And if you do your huddles around that communication board, you can make sure then that everybody gets the latest information up to date. So thank you.
Yeah, and how do you like huddles?
The very few and very easy ones to put into place. Oh, I love huddles.
Yeah.
We could do a whole talk on huddles. So it's really, having an effective huddle is very important these days, and making sure that you're including your physician partners in your shift huddles. Very, very important.
Yeah. All right. Hey, Nick, what are your volume projections for 2021? What's your crystal ball say?
Well, my crystal ball is that nobody really knows. But when you look at the trends, I do think that we will get back to normal. Well, we'll see an increase. Whether that occurs in 2021, 2022, when that occurs, I don't know. We will probably continue the trend of less children, less ESI 4s and 5s. We've been seeing that trend over the last 15, 20 years. We'll also continue the trend of more sick patients, more older patients, and more psychiatric patients, or behavioral health patients, I guess is the PC way of saying it now. But I do think that volumes nationally, up until the surge in the last few weeks, have leveled off. We've recovered from the great dip that we had, and I think it will inch up going forward.
Yeah, I think, what about other panelists? Isn't that what you're seeing? Some departments down 40% at the height of the pandemic, people creeping back up, but the ESI distribution, the acuity distributions are very different. I visited an ER last week that has only 3% ESI 4s and 5s. 3%. You can't populate a fast track. What's that ER going to look like? And so I think that's some of the changes. Anybody else? What have you seen? I think everyone's probably interested in knowing is what's going on with me, what's going on with other people.
Hi, Shari. Mike Granovsky here. Thank you for that really important topic. We track some of our groups on a regular basis, looking at roughly 400 sites across the country. And to Nick's point, we are seeing decreased volume still. Maybe we were down 50% across those 400 sites at, sort of the nadir. And now blended nationwide, those 400 sites are down 15%, 17%. There's a dearth of peds though. The peds population is down still 40%. And at its maximum was down almost 80%. The admission rate, on the other hand, the acuity has gone up significantly, roughly 20%. So if you were a 20% admission shop, you're now 24%. And the coding has moved proportionally to that higher complexity patient. And, obviously that's going to change the way that we practice and the staffing and the use of mid-levels and our triage processes.
Yeah, excellent points. It's going to impact everything because what we're doing now is not what we were doing even 6 months ago. Anybody else want to chime in on that? All right. Jim, I think you were going to say something about that.
Yes, I sure was. Some of this is our own design. We have certainly seen the volume drops, and that's what I reported on in my session. What comes back to us kind of is what we design it to do. And I'll speak in particular to low acuity. Are you going to set up telemedicine as an alternative for lower acuity visits? Are you going to work through local urgent care centers? Are you going to work with local EMS to triage low acuity patients away from the EDs? And then very importantly, what are we going to do with the mental health chemical abuse patients in our community? And in some places, there are really good programs for sobering centers and similar substance abuse and mental health crisis centers. If we do nothing, that volume will absolutely come to the emergency department, and it could be significant in many communities. If we rally around these new program ideas and find a great place to manage those patients that frankly is better than the ED in some circumstances, I think we'll have that volume decrease, and we'll be back to managing what we're really good at managing, sick and injured people that are what EDs were designed for.
But you know what, in the meantime, is this true, Nick? You're probably closer to answer this question, and I'm sure there are many listeners that would have some information on this score. Are we not training residents in behavioral health? Is there not a behavioral health standard rotation, just like you rotate through trauma and OB and so forth, in most residencies for emergency medicine? I think there's not. What do you know about that, Nick?
Well, most of EM training has gone from set-alone rotations in orthopedics, trauma, back into the emergency department. And because our behavioral health volume has gone up, that is a bigger component of what our residents are seeing. But if you look at the model for EM training, that hasn't budged too much to put a bigger emphasis on the behavioral health. So I do believe that we're going to have to do that from a training point of view. And if I may follow up.
Training for this decade, maybe not.
Correct. And Jim has shown those slides over the years Back in the 1980s, we were 50% injury, 50% illness. Well, the percent of mental health is now significant, and injury has gone down through all of our injury prevention
They actually rival
methods.
each other, don't they? If you look at injury and mental health, Jim, isn't true? They're like almost on a par right now.
In many places they are, yes, Shari.
Yeah.
And one thing to follow up on what Mike was saying, even though we're seeing, and let's just throw out a number, a 15% drop in patient volume, we're going to have to be very careful as leaders to make sure that we do not get a 15% cut in our budget for next year, because the patients we're seeing are much sicker. As Mike says, your admission rates are going up 10, 20%, and that means the number of hours boarding is going up. All the patients we're seeing are requiring more resources, even though the volumes are down. So anyone who staffs or budgets based on numbers is going to get it completely wrong in 2021.
Yeah. You're right.
I agree that
I'll say we need a correction factor for boarding, my friends, from everything from staffing, scheduling, reimbursement. We need a correction factor for boarding badly, because there's nothing out there now that does that, just for all the reasons that you said. Mike Gibbons, I got a tough question for you here from someone. How many phlebotomists do you need in a 50,000 visit ER?
That is a very good question. I mean, there are so many variables. It really, I would say it depends. I got by in a 40,000 visit ER with one phlebotomist 24/7, 10 years ago. But with the advent, or with the addition or initiation of physician and triage models, are you working in a level 1 trauma center? I mean, it's a really difficult question to answer. But if you use 40,000 as a baseline, and you had 3.2 FTEs, which is one person 24/7, I mean, that's a good place to start to make that consideration. So 50,000, if you double staffed for 8 hours in the middle of the day, Monday through Friday, probably not a bad place to start.
Yeah. Well, and the other thing is, are your nurses still drawing blood from an IV? Because of hemolysis and contamination, a lot of places are going away from that.
Right.
We thought it was a best practice, and now we're going away from it. Pam, what are your thoughts on this? You've managed a lot of ERs. What are you thinking about?
Yeah, I think just kind of build off what Mike was talking about is understanding your numbers. I mean, that's a lot of what this is. When we talk about operations on the nursing side, is you got to understand your numbers. You need to look at when you're drawing your labs, the type of draws you're doing, and then also the geography of your department will make a big impact on this, because sometimes some people think, well, we're going to get a phlebotomist and only they're going to draw the labs. But if you're a 60, 70,000 visit and you have one phlebotomist on, now you're creating another bottleneck. So again, it's understanding your data and your arrival patterns, and then your lab draw patterns.
And
Yes.
then the other important thing to note is, if you're going to have those same phlebotomists be responsible for any point of care testing you're going to have, that's going to take them out of the mix for being able to acquire those samples.
Yeah, that will keep them busy in and of itself in some places. So, okay, Mike Granovsky, I'm going to ask you a question, and I don't quite know what it means, but someone smart has submitted this question. Will medication-assisted treatment be a reimbursable service in the ED for 2021? What am I talking about?
Yeah, that's great. Thank you, Shari. And Jim Augustine brought up the initial point that we're going to see more and more mental health and opioid use disorder patients in our emergency department, and more ED providers, whether they're getting an X waiver so they can start Suboxone, or they're operating outside of the X waiver requirement, which we can do in the emergency department under what's called the 3-day rule, are interested in initiating Suboxone and other medications to help opioid use disorder patients move away from that vicious cycle. However, it's a lot of work, and they have a long length of stay. And we previously didn't have a reimbursement paradigm for that service, medication-assisted treatment. And in the final rule that was released just 4 days ago, we have a new code, G2213, and it's initiation of medication for the treatment of opioid use disorder and it calls out in the emergency department setting. And it's got 1.3 work RVUs and 1.89 total RVUs. So a really nice addition to the reimbursement armamentarium for work that many EDs are passionate about and interested in pursuing, but didn't have any way to generate revenue to justify resources for it.
Oh, that's excellent. So as of 4 days ago, folks, you are really getting cutting edge information here.
That's right. We're on the edge.
There you go. And
Mike,
I'm like,
Mike, who's going to pay? Who's going to pay that? Is it
So that's-
guaranteed for Medicare and Medicaid and commercials?
Yeah, great question, Jim. Thank you. So that came out of the Medicare physician fee schedule rule. So Medicare will pay for it, and it'll be state by state whether Medicaid does. Medicaid obviously is a big payer, but we're starting to see a lot of interest from the time the proposed rule came out in July, August, of state Medicaids also reimbursing for it. That obviously will be a big component of the payer mix.
I guess we all better learn about Suboxone, huh?
And if I may, that's really sure that is an important thing, because for so many years we would see patients who survived their opiate overdose, and it was 3 o'clock in the morning. We had nothing for them. They don't have insurance. There was no place for them to go. The treatment areas we had were overflowing. Now with Suboxone, it's been shown to be more effective than previous treatment methods, and it is something that we can start. So we have a proven effective therapy, and bonus points, we could get paid for it.
You know, actually, the mortality rate has been decreased 50% with that drug. And it's one of those things where I'm not quite sure why most emergency departments don't have a Suboxone program, because what you really need is some primary care doctors who are willing to follow them up and then integrate into it some of the hospital's social services. And the next thing you know, you've got a program where before it was discharged to patients, which was just not there. It was just going to be a vicious cycle again.
You know, how about this observation, you guys? Emergency physicians, we have stepped up for every, sort of urgent thing that could come to our doors, right? We learned to be ENT. We learned how to pack noses. We learned how to do difficult Coude catheters. I mean, we've learned to do so much, but for some reason, it's always been like this with behavioral health. And I'm feeling like, maybe now is the time, since they are such a big part of our book of business, of the problems that present to us. Maybe it's time for us to get a basic set of skills for managing the behavioral health crises that come in. And the other thing is we've overwhelmed a lot of the resources in our community. So maybe we are the solution.
Well,
and it's time for us to
let me push this one more level. What about the patients who come in who are suicidal, who now will be getting infusions of ketamine? I mean, has anybody embraced that into their practice? I mean, this stuff works. And before it was like, well, we really don't have much to do. And we hope that if they go out, they're not going to, do something, harmful. And I've seen a case in an ER setting where people would come back repetitively for IV ketamine because they were in a rural area, didn't have any psychiatrists, they had no other options. And so I do think that there's opportunities for us in the acute treatment of people who have,
like, would this fall under the new filling and coding, giving a ketamine infusion for depression in the ER?
So the definition of the code, Shari, is treatment of opioid use disorder. But the patient that Rick just described would be a good observation patient.
Yeah.
So you go from an ED code that's maybe 5 RVUs to an OBS code that could be as high as 7+ RVUs. We should do things, the right reason for the right patient.
Yeah.
But there is a reimbursement paradigm for that extra work.
My daughter's a psychiatry intern, you guys. She just started and she thinks IV ketamine is the coolest thing ever. She's got her little caseload that she's believes is very successful. So there you go. All right. Hey, how about Mike, in terms of trying to engage radiology and the ER in ED work and improvements, what have you found is the best way to get them involved?
Thanks, Shari. Great question. There really is no best way. There is only try and try again. I've never gone to an ER where radiology didn't complain about something that the ER was doing, and the ER was complaining about something radiology was doing. So it sets up a perfect platform for negotiation. So as leaders of the departments come together and look for commonality in terms of patient throughput. I guarantee you that radiology is frustrated that your patients are never ready when you tell them they are, or when they come to get them, because they're still clothed, they still have jewelry on, yada yada yada, and they never do the test fast enough for us. So if you can start with those two common themes and try to help one another in that respect, I think that is a good bridge building perspective to get positive movement going forward.
And I think you also like shared transport of imaging patients. Don't you like that strategy?
Yeah, I mean, if you can't afford the resource to dedicate it specifically, if the ER would fund half of an FTE and the radiology department fund the other half, the last thing we want is a rad tech running around pushing patients. They need to be at the machine positioning and pushing the button. Ideally, ER staff can take the patient to radiology, radiology can bring them back. That's probably the most common scenario that we see.
And I'm thinking it's a nice sort of olive branch to radiology as you're trying to work on improvements together. If you say, hey, look, we'll help push those gurneys over to you. So anybody else seen anything or want to chime in on that? Okay, let's go. Jim, here's another one for you. What are the action items that an ED should be doing to prepare post-pandemic?
We've mentioned some of these already, but I think significantly higher acuity and significantly more geriatric patients are our future. In some communities, I think the ED as a hub for the telemedicine program will be critically important, and some of the emergency physicians' time dedicated to telemedicine. I have seen some of these models where the physicians and APPs are used skillfully to address EMS needs and an occasional set of needs that comes from, like, our partner Bruce Janiak, who did a lot of the nursing home medical direction out of the emergency department. I think those are two very important items. Another one, I have to say, post-pandemic, we have been given a reprieve from many of the active shooter events because soft targets have disappeared. If you want to think about it that way, the mall, sporting events, et cetera, not the soft targets they used to be. We're not having concerts and big events at nightclubs and other places. I am very concerned that when the pandemic ends, we will be back to a period of time where terrorist events will occur, and emergency departments are going to have to be set up for those. That requires a different approach to the front end of the ED, which is outside, greeting patients out there, as we have seen happen with the events that did occur. And that's unfortunately a part of our future as well.
And actually that tent outside seems to be a very common model for dealing with a COVID surge and managing those people that need testing without bringing them into the ED. Do you like that, Jim? Do you feel like that's the most nimble response to a little surge in your area?
Yeah, I have to tell you, I'm very disappointed that we've resorted to tent operations. And I think it represents a very, very poor attempt by hospitals to build a front end to the emergency department that should be a hard build. In all of my design consults, I have said, trying to fit a tent outside and think about weather and power it and make the computers work and bring water, et cetera, is actually an abomination. And we should very clearly be building hard space, making it flexible and usable on a day-to-day basis, but available for surge, and then much safer for our staff to be using it, and built with the accommodations we need, like electricity and Wi-Fi and heating or air conditioning, and not having to go through that tent event. I'm sorry.
Jim, you're so wishy-washy about this. Where do you stand?
I know more places that have done a tent than have done anything else, actually. What about the rest of you? What have you seen?
Well, I think I'd like to add on to what Jim's saying here. I mean, from an operational standpoint, if you look at our numbers, and if we're having such a big decrease in our low acuity, why are we not repurposing? Because usually the low acuity is closer to the front end of your emergency department. Are we repurposing our areas? And coming out of this, we're going to have to take a hard look at that of our with what's within our four walls of the department, that we need to be able to do that. So
And I find most ERs don't realize it's your geography, my friends. It's your real estate. What do you want to do with it? You know what I mean? They really have more chances to innovate. And I really like what she just said, didn't you guys? That, hey, if the low acuity ain't coming, why don't we make this a COVID hot zone? Why not? You know? Yeah. So very clever. All right, Nick. I already asked you those two questions. Sorry. What about, would you echo what Jim said about changing your design and flow with COVID? Do you like what he said? Have you got a different perspective on that?
Absolutely. Jim and Pam both have really good ideas. The one thing that we haven't talked about, though, is we need to have some way within our departments to accommodate the need for PPE and keeping people clean. So very few departments have, for example, showers for staff to take and change into street clothes afterwards. That's going to be a must. The hard part of donning and doffing in your hallway outside of your exam room as patients are whizzing by, we need to have a hard strategy about that, in addition to the limited flow rooms to keep people safe. So we have all kinds of things that need to change to protect against infectious diseases.
And kind of in a related thing, Pam, this question would be coming to you, I think. Communication, especially when we're limiting families and limiting the number of people that come into a department, what can be done to improve that patient and family experience, given all of these constraints with the movement of people in the pandemic?
And I think this is something now I can talk about what you can do now, and what I've heard is being done from some of the nurse leaders across the country, but also take it into consideration of going forward is first of all, your patient call system. Do you have one that you can communicate either from outside the room? Some of them are connected to our phones. If you've gone to the iPhone technology, you can communicate without having to go in and out of the room. And then setting up a three-way call. So when we've made our disposition, or we need to include the family in on decision-making, we'd set up a three-way call. So all of this needs to be done up front when the patient first arrives. Set up those communication expectations of what you can do, and then make sure you have a good number that somebody will answer when the doc is ready and they call. And so those are some of the ways to do that. I think the biggest thing right now is use your technology we have, because it could be just a phone in the room. Call the phone in the room, limit that going in and out, but then looping our family in. But if you don't set that expectation up on front, you're gonna have a no-win situation. So
could I add to that, please, and kind of reinforce what Nick was saying? Our use of communications technology is lagging behind what we're asked to do. And I'm gonna particularly point out the nurses who, in attempting to take care of COVID patients, are having to don and doff, and in between they're on a phone or on a radio. We had attempted to use Vocera type technology in the past. We need to do much better into the future. And when a nurse or a physician or APP is gloved up and in protective wear, that they can still communicate effectively with whoever they need to. We are lagging way behind in the communication systems. And right now we also need them to communicate with the family members. But more importantly, just the very important communication technology. You have to leave the room to use the computer. You have to leave the room to use the phone, or to do something that's been accomplished partially by intercom. We are lagging behind and clearly need to address.
Yeah.
That's a good point, Jim. I think using the headsets with the mic under the PPE is one of the best ways right now to do that. And but it has to be either Bluetooth or voice activated or something, again, because of the PPE. And it's not an easy solution for hospitals to face.
Mike, will reimbursement ever catch up to the real world, which involves often spending a lot of time talking to families, especially as we do more and more end of life in the ED, and we're encouraged to do that? These discussions take time. Do you see any give there? Will there ever be, an opportunity for the thing that you may spend the most time doing, which is talking and communicating with patients and their families. What are you thinking?
I think if we look at time specifically in the ED, that it's unlikely that we will be measured and paid based on time. If you look at the 2021 CPT book right now, it actually states that emergency department services are provided on a variable intensity basis, with providers often caring for multiple patients at the same time. So way down in the complex RVU assignment, processes, time has been removed from our code. So we're then left sort of one instance, one clinical circumstance individually. For instance, end of life care. Well, there are codes to represent end of life care, but then there's, what about the time that you spend working out a discharge to home for somebody who has a complex home situation? We don't quite have those captured just yet. And I agree that, a good future would reimburse us for all of the sort of cognitive, but also some of the social issues that we're addressing. And we're not quite there yet.
Yeah. Let's see, I have one last question that came from our audience, and this takes us back to one of our muckety mucks at the Benchmarking Alliance. What about left without treatment? Someone asked the question, how do we define it? How do we measure it? Who wants to run with this? Because we all know it's a muckety muck.
I've got it.
Yeah,
I've got it. So one of the things that we've been doing at the Benchmarking Alliance is trying to define the terms that we use every day that we all think we know. And that has been the subject of several of the EDBA summits. And at the third summit in 2014, the left patients leaving was a huge topic. And so as you saw on Jim's slide, the current terminology is left before treatment complete. And that encompasses people who weren't treated, partially treated, eloped, left AMA, all that kind of stuff. If you're interested in this and a more formal discussion of this, it's free online. The results of that summit was published in SAM's journal, Academic Emergency Medicine, in their May 2015 issue. And again, that's free online. Just go ahead and look it up. Academic Emergency Medicine, May 2015 issue. And there's a very good definition. There's even a beautiful picture of the whole concept. We included everything in there because some people are only reporting left before treatment, left part of treatment, AMA is separate. What we at the Benchmarking Alliance say is everyone who leaves before they were supposed to counts. And that number is what we track. That number is hard to game. That way we compare apples to apples across the board. And so that's the number that we use.
And everyone should know that this is probably one of the least standardized of things that are measured in our specialty. Jim, don't you agree? I mean, I've seen so many different buckets for the walkaways, left after medical screening exam with labs, left before, just there are so many competitive, and what's eloped compared to left without being seen. It's still very dirty. And you said this, Jim, 20 years ago, that these buckets were dirty and we should just measure them as a global measure. And, despite all the computer timestamps, I think it's as mucky as it's ever been. What do you think, Jim?
Well, I'll use the word cheating. And this is where emergency department leaders cheat most routinely. They want that number to look low. So they decide that anybody who walks away, they're going to give a different term to and not count it. And it makes comparing operations impossible. It is very dishonest, and therefore combining all of those together. If you internally want to be able to dissect in whatever method is appropriate for your process, go ahead and do that, but don't report on a partial left before you're supposed to amount and comparing to others. And don't be dishonest to yourself and to your staff that some way you're not satisfying needs that patients are staying there. And I think that's really important. And we are still working, Shari, with all of the vendors to make sure that those definitions are standardized as well, and that they can't cheat by inserting a different definition for left before.
Yes, and I think that's key, and that's the only way. We have to clean this up ourselves, folks, or somebody's going to come in and try to clean it up for us, and it's going to be a rough go. So, folks, that's all of the questions that were submitted to us. Any of my Brady Bunch panelists have any last pearls they'd like to share before we sign off? Anybody?
I'd like to hear from everybody what they think of operations in 2021.
Just in general operations.
What is going to change in 2021? What's putting our best foot forward in the emergency system? I think everybody here has a valuable opinion. I wish we could get 205 of them from the audience, but let's just start with the group that's here on the screen.
Anybody want to dive in? So
well, let me start. I'll volunteer here. Somebody's got to be first, So one of the things that I'm concerned about, that I'm reading about, is this growing tension between physicians and advanced practice providers with regards to who's going to work the hours, what is the staffing arrangement going to be? Are physicians going to be marginalized, but to some degree, by AP advanced practice providers, because their salaries are, $130,000 versus physician salary? And I know physicians who have been replaced by these folks, and these folks are becoming progressively interested in advanced practice provisions where they can autonomously practice, and that California just passed. They've been resisting that for decades and decades. It passed this past January, and although I clearly believe that there's a room for collaboration, I do see some tension between these two groups when shifts are being cut down.
Well, we introduced APPs into our world when the fast track lower acuity population was very robust. Does anybody remember when I started, 25 to 40% of patients could be seen in a fast track. It was a perfect fit for an APP to see these lower acuity patients. I think now the tension, what if you are an ER like the one I mentioned, and only 3% of your patient are low acuity, the rest are complicated, they're old, they have 28 medications. They often become outside the scope of some APPs, not all. There are many that are very experienced, very knowledgeable, and so forth. Too bad they're all in one bucket, but they are. I think this is part of the tension, is that our practice has changed. And so staffing needs to change. And at the same time, there's a pressure to go for the lower cost provider, who would be them, not us. And I think that tension's here to stay for a bit. What else does anybody else think?
I can talk on the hospital, probably operation side, because I am thinking from the ED operations is going to really be impacted in 2021 by this, the dynamics change of the type of patients we're seeing. And I think nurse leaders are going to struggle with being able to justify the staffing they need for increased holds, increased acuity. And then how do we staff that? I think that's probably going to be one of their biggest challenges in 2021. And it's, again, really understanding how to present a very much a business model to the executive team to support the needs that we need to have to give safe patient care, and then maintain retention of the nurses we have. So I really think that's going to be a big challenge, along with meeting any new quality metrics that are going to come out of this, because I think there's going to be several more that's coming out. So
yeah, I agree with you, Pam. I've gotten a lot of questions sent directly to info@edbenchmarking.org over the last several months regarding nurse staffing, particularly after we published our 2019 report. And people are, there's some of the targets that these labor management companies are giving their CFOs are just, they're ridiculous. Worked hours per unit of service at 2.25 for a level 1 trauma center, 2.5 for a level 2 trauma center. That's and even looking at pre-COVID numbers, that is stretching to something way beyond whatever I was ever comfortable with.
So I would echo Pam's sentiment, and we really need to work on being able to make a business case, because we're the only ones that have the information. And don't let anybody push you into cutting staff in 2021, because you are only going to need more.
Yeah, and it's going to be very important in that business model to tie in the patient experience, because again, of the reimbursement model that will be coming with the patient experience, we need to make sure that we tie that in, because those tight measures like Mike was just talking about, you can't have good patient experience.
There's a couple of emerging strategies that I wonder if you guys are aware of for boarding. And by the way, I'm just seeing boarding go up unless a hospital really works on early inpatient discharges to open up capacity. The boarding problem, every place we go, it's higher and higher. If we look this year, it's higher than last year. A couple of mitigation strategies. Some places are routinely sending nurses to the bedside in the ER to help care for those patients that are admitted but still hanging out in the ER. Then the next level is I'm seeing places where providers, say a hospitalist hit team or on-call team, will come to the bedside. That still doesn't take care of the problem, which is it's our beds and our real estate now occupied by inpatients. And even when they send the help, that still creates problems for us. We're congested already. Mm-hmm. And so I think we're going to see more and more work. The admission holding unit, which was first written about by Temple, it's a one solution of trying to find a place to cohort admitted patients who don't need the intensity of the ED anymore. And now that we've got some codes to bill for it, this might become more and more viable, to have these admission holding units. But I think mitigating boarding is going to be one of the biggest challenges that ERs are going to be faced with. Anybody else?
Shari, I remain hopeful that the expansion of telemedicine and the recognition by the payers will remain intact as we move forward. The rule that we just discussed that was released really just a few days ago allowed for the ED 99281 through 99285 codes to remain on the approved telehealth list, not only during the public health emergency, but until the end of the year during which the public health emergency ends. I think we all kind of hope it ends in 2021, but let's say we're to end in April of 2021. That would give us a whole lot more runway to then lobby for telehealth to be permanently approved for ED use. And in fact, for rural teaching physicians, telemedicine is now permanently approved. That's brand new as of 5 days ago. So the resident supervision that's required for that key critical portion, that can now be done for rural physicians. And it's a very tight definition of rural. You have to be outside of a metropolitan statistical area, and it has to be based on where the residency is located, but it's a start. So I'm hopeful that telemedicine remains supported by the payers because it's a huge, huge value to our patients.
And couldn't you see it dovetailing nicely with efforts to reduce the so-called avoidable admissions, those people that are on the edge, maybe there's social reasons that you decide, oh, I better bring that person in. If we had a good hardwired telehealth system, that could help as well in reducing some of those admissions that are a little softer, that could be managed if we had nice, tight follow-up. Nick, did you want to add to that?
No, I agree. Telehealth is going to be a very important thing. The other thing I see is I'm worrying about if there's any fallout to the economy from people that have been unemployed for 6, 8, 9, 12 months. That their PCPs aren't going to see them. So there'll be an increased burden on us to take care of them. And they're going to be sicker because they've lost a year worth of wages and a year's worth of health care. So that's what I see is going to be a huge issue for us.
Yeah, I think you're right. Who wants the last word? Anyone?
In the next 2 weeks, we're going to have 2 COVID vaccines out with the information that comes along to be aware of the safety and effectiveness. We may have 2 more in January. I think that's going to be a game changer for us. Very important for our staffs. Very important that we plan for our communities to be getting the vaccines when they come available. I think that's the best news we can have.
Distribution? Jim, do you see ERs being part of distribution?
In very few places. It's a public health effort, and the intent is to keep them away from the ED, which is already a troubled spot. But our parking lots and other areas around, and if we have an opportunity to immunize somebody who's within our space, we might have to take the opportunity to do that. And certainly us heading out and working with public health and administering vaccines in places like congregate care facilities may be a role for emergency department staffs who need a little bit more work to do.
Yeah, right.
Yeah, I want all the vaccines. I'll take Moderna. I want Pfizer. As many as possible.
I've got my arm out. I'm ready. Well, all right, folks, we hope that you've enjoyed it as much as we have. We really enjoyed having you part of our little program. And keep in mind, more to follow next November 15th through the 17th in New Orleans. Thanks you very much. Bye-bye, Brady Bunch.
Bye-bye.
Bye-bye.
Bye.
Bye.